Well, hello, everybody. My name is Garrett Schmidt, and I'm the managing editor and CEO of VBC ExhibitHall. And I'd like to welcome you all to today's live webinar slash discussion that is hosted by Patient 360 with special guest Tandem. And this is going to be a little different format than what we normally do. This is going to be kind of in the format of a fireside chat. And the title, the official title of today's discussion is Implementing eCQM Reporting, success stories and professional tips from an early adopter. But there's going to be a lot of back and forth discussion. We are going to have some time for some Q&A towards the end. So if you have a question for either of our speakers, you can go ahead and drop it at any time in your attendee module. There's a place for questions. So again, you don't have to wait until Q&A to do that. Just go ahead and put that in. We're going to get to as many of those as we can during the allotted time. If for some reason we aren't able to get to yours today, don't worry. Someone will reach out via email to make sure that we answer your question. So even if we're wrapping up at the last second, go ahead and ask your question. Also, today's session is being recorded. So what's going to happen is when we conclude, about an hour or so afterwards, you'll receive an email and there will be a link to the recording as well as to where you can download the slides and follow along. And that way, if you want to review it again or share it with your colleagues, you can do so, and we hope that you do. So without further ado, I wanted to introduce our speakers today. And I think you're going to be very impressed. We have a dynamic duo with us today. So first of all, we have Miss Tiara Swindell. And Tiara is a recognized leader in population health management and was honored as one of modern healthcare's 40 under 40 in 2024 for her exceptional contributions to the healthcare industry. As a key leader at Tandem Health, she plays an instrumental role in driving the company's mission to improve healthcare quality in the greater Philadelphia region, while driving cost efficiency through validated health management tools, proprietary clinical support services, and a value-based financial incentive model. Under Tiara's leadership, Tandem has achieved significant milestones, including the successful launch of 3 ACOs in just 3 years, enhancing the region's healthcare strategy, and expanding access to high-quality care. She has also spearheaded Tandem's early adoption of electronic clinical quality measures, which are eCQMs, reporting in 2022, a forward-thinking initiative that enabled the company to achieve shared savings in both 2022 and 2023. Her diverse career spans from frontline operations to leading the growth of population health services for hospitals and independent provider practices. And her broad expertise equips her with a comprehensive perspective on the rapidly evolving healthcare landscape. And she continues to be a powerful advocate for innovation, collaboration, and improved patient outcomes in healthcare delivery. And we also have with us Miss Amanda Lord, and she is she is the Chief Operating Officer for Patient 360 and has been there since 2014, where she leads the subject matter expert team. Her leadership focuses on leveraging best practices, optimizing client value, and developing strong partnerships. And she leads a seasoned team consisting of professionals and thought leaders who collaborate closely with CMS to ensure clients are well informed and prepared for regulatory requirements. And it is important to call attention that Amanda's team is one of the first to successfully support multiple early adopter ACOs to harness the APP program dating back to the program's inception in 2022 performance year, and continues to support ACO's adoption of the program. So, as I said, we've got kind of an all-star team with us today for a very interesting conversation. And so to get started, though, I wanted to, before they take over, we wanted to briefly get to know our audience and see who is with us today. And I thought you might be curious as well, and we're going to show you this result. And here is the question. It's going to pop up on your screen. When is or was your first APP reporting year? And the answers are anonymous here, so you can feel free to answer accurately. And just thought this might be interesting to kind of get a perspective, see who's with us on the call today. And again, we'll show the results here shortly. The first question is, was it before the 2024 performance year? Was it 2024? visit the 2025 performance year will be our first year, or we do not participate in APP reporting. And if it's non-applicable, I guess the we do not participate would be your choice there. So we're going to give folks another few seconds to answer the question here, and then we will show the results. Okay, looks like most of you have answered at this point. So I'm going to go ahead and close it down in another 10 seconds here. Okay, and again, when is or was your first APP reporting year? And if you're just joining us, we're doing a poll to get to know our audience. All right, I'm going to go ahead and shut it down in 5, 4, 3, 2, and 1. And let me go ahead and share these results. All right, Amanda and Tiara, are you able to see the results on your screen?
Yeah, it looks like we've got a good mix. I see there's some newbies, so good. This is going to be helpful, and then it's going to be good for those who have already submitted prior to 2024 to look at some best practices, review some lessons learned from Tiara here. So yeah, we've got a nice mix. So I think this will speak to everyone, and we'll try to keep it very collaborative. And I might start off with Tiara. I won't put you on the spot too much with the first. Tell us about yourself, because we've heard all about you, and it's very impressive, the 40 under 40. I think for folks listening, let's hear a little bit about your journey at Tandem, sort of when you started at Tandem, and then maybe a little bit more about the Tandem profile itself.
Yep, absolutely. So I have been here with Tandem for 3 years now. I've enjoyed my time here. As we have heard, our kind of mission and value is about bringing population health and value-based services to the Philadelphia region. Right now, we have MSSP ACOs as well as some Medicare Advantage contracts. We serve roughly 170,000 patient lives spread across the region. Of that, specifically for MSSP, we house just over 60,000 lives across our 3 different ACOs. So a lot of good work happening here, I think, on the Tandem side, and trying to make sure that both our hospital partners and independent practice partners are kind of succeeding in their journey with value-based care.
And you are obviously, everyone knows listening into this call that you were an early adopter. And so curious for some of those out there listening that may have also been early adopters, what were some of your drivers for early adoption for APP reporting?
A few of my drivers were really just trying to be a bit ahead. Our first ACO started in 2022. So for that particular group, there was not a huge transition that we would have to make coming off of DreepPro from a learning standpoint, DreepPro or web interface. But there wasn't a huge learning curve that we had to take on there. So we really had some focused conversations with our ACO partners that were in that ACO to say, we have these options. We have eCQMs, we have CQMs, we have web interface. Let's weigh a little bit of the pros and cons of doing each of these. We did dual report in their very first year, but ultimately kind of for them and us, we kind of really wanted to focus on eCQMs, just hearing how CMS's plan is for quality. They introduced eCQMs, CQMs. They told us in the beginning CQMs wasn't going to be the end all be all, because eventually the digital quality measures would come into play. So really decided that, from a best effort standpoint, making sure that we are not changing methodology or scripting with our providers and practices somewhere in the interim, that we really want to go ahead and take advantage of the bonus opportunity that we had coming in from CMS, as well as just understanding the profile of all of our groups to just go ahead and work with eCQMs.
And speaking of the profile of those groups, so you've got the 3 ACOs, about how many member TINs in each ACO, and then a little bit more about the EHRs that those TINs are on. Are they mostly certified 2015 EHR technology? So let's hear a little bit more about the member TINs and the EHRs that they're on.
Yep. So EMRs, I will say Largely, I will say they're probably your more common EMRs, Epic, ECW, kind of the Medent, some of the larger ones. We do have a couple of practices that are on what I would call a little bit more disparate EMRs, where it's not really easy to pull the data out and or use the data. But across each of them, roughly speaking, from a participant 10 level, there's probably 3 to 4 participant 10s within there. But from a practice standpoint, between all 3 of them, our largest has just over 160 practices total. And then our smallest one has roughly 25 practices. Our profile of each of those all include specialty practices. So we do have to have some considerations in how we're educating and teaching and looking at the measures from a PCP versus specialist perspective. And then each of those also contain a hospital system. So we have independence mixed with, the hospital system as well as the specialty docs.
And so with the various TINs, in terms of early adoption, what, how did you prepare them? How did you pull them out of the comfort zone of web interface into APP reporting, right? I mean, I know for some, there was probably a lot of early education, but how did you educate them and get them out of that comfort zone of web interface? Because I mean, gosh, web interface has been around forever. So just curious to know some of, what you were doing early on to get them into the comfort zone and to say, look, we are making this transition and here's what needs to happen to make it successful.
Yeah, I would say that transition probably for us is probably a little bit harder on what I would consider the specialty side, hospital-based medicine, as opposed to our PCPs. A lot of our PCP groups were involved in other CMMI programs, like Primary Care First or CPC Plus previously. So eCQMs was not completely new. What we tried to do in the beginning and trying to figure out, how do we educate? Where's the best place for a dialogue? We definitely leaned in with our medical and clinical leadership to think about, providers are at the center of this. We don't expect them to be the ones in the EMR making sure it's in the standard fill all the time, but they do have their staff members. So it's important for them to understand and recognize what they should be seeing. So when it's not there, it's not in the structured field, they know to ask, their MA or whomever to go back and, can you pull this in the correct way? So our base was really looking at organizationally for each of those ACOs, what does leadership want to lean into? How do we then make sure we pass that education down to all of our physicians? And then we had a separate education and training very specifically for the staff. The questions that we found coming from the staff versus the provider are not necessarily the same, but we think that the attention to detail and the knowledge base is important on both fronts. So really making sure we have some type of education, designed for doctor versus staff, and
Different
then
audience.
what are we going to look at to measure our performance on the leadership level.
Yeah, so different audiences and making it applicable accordingly. In terms of resources, so because this kind of leads into my next question, and there's a level of effort, right? You've got to align all of your resources. So about how many people to make this successful were on your team, and sort of what did that ACO project team look like? About how many resources did you align with Patient 360 and what were their roles? Because this is part of, you were just talking about, okay, we had staff that were working on education, this, that. So about how many resources, just to give the newbies out there a sense. And then maybe those that are listening that have already reported, maybe they need to realign resources or think about other resources to make the project successful.
Yeah. So roughly speaking, I want to say about 4 people, at least on our starter 2, a larger one, which is the biggest. The team that is kind of project managing this has been roughly 10, just due to their size. I think kind of important there is making sure you have someone that's on point for quality, that's really going to be able to deep dive into the measures.
So, yeah,
Someone that is good with the EMR to make sure that the measure specs are built correctly, which you guys helped us a lot with that. So we took it upon ourselves to make sure they actually have the measure showing up in their dashboard. They could produce the file, I think, and then we kind of leaned in with you guys to say, is the file actually right? And I think that that is a huge piece to make sure it happens, because as we learn, QRDAs, while there's some standardization, it's not what is the word I'm looking for? CMS has like a bare minimum to fill in for that QRDA file, right?
Yeah.
Sometimes when we wanted reporting, you guys would let us know, like, hey, this EMR, this group is not sending over X data set, and you guys were able to help us navigate that. I think having that EMR vendor conversation is key, and then making sure that whatever vendor you're going to work with, there's some relationship or comfort with that vendor being willing to discuss with the actual EMR vendor what might be going wrong. I know early on we had recognized there was an issue with one of our EMR vendors in the depression screening measure, and you guys were right there with us to kind of lean in and answer some of those technical questions that some of us on the front end may not be used to or equipped to answer.
Yep. And was the look and the feel of the resources that you have now for APP, how different is that from the resources that you were utilizing during G-Pro reporting? Is it quite a difference?
There's a pretty big difference. When we did our dual reporting in 22, we had a team of 16 to get through that reporting. Now I think our primary team is a team of 2. Someone that's really kind of working out there with the practice, and then who we're using for our communications with you as our vendor to make sure everything's coming in, getting processed the way it's supposed to. So I think once you get off the ground and you kind of get into the habit and the swing of things, I think the work effort completely goes down from where it is when you're first trying to get involved with eCQMs and you have to go through the education, because eventually that education, knock on wood, assuming CMS keeps the measures relatively the same, doesn't change that much year over year.
We're going to keep adding them, but yeah,
They will, but it's not a complete overhaul that we started off with.
yeah. At least we kind of knew slow roll. It's a slow roll. We know, and we'll talk
Yeah.
about this later with the 2025 final rule. We know that 112 is coming and others are on the docket, but they're not unfamiliar measures, as you previously mentioned, right? A lot of
Mhm.
these measures, breast cancer screening has been around and it's been a quality measure in the program for a while. So these are not
Yep.
unfamiliar. I think when we're talking about managing resources and leveraging those resources, one of the biggest concerns I've noticed and I've seen over time is TIN education, communication, and outreach. I think you've really got it nailed down. And I know this because on our recent call with your staff, I mean, we're almost ready to submit the data, right? All we have
Mhm.
is just, of course, the remaining of December data, right? As everyone does, because we're still in December. But it's pretty much caught up. It's looking really good. The scores are great. So I know that you are in a good place now with your member TINs and communicating and getting everything that's required. I think a lot of ACOs out there are nervous. There's some trepidation about how are we managing? How are we best managing? First of all, how are we getting our TINs engaged? I know we can say education, but what are some of the actual strategies you used early on to get these TINs on board and to be doing what they're supposed to do when they're supposed to be doing it?
Yep. So we annually try to host just a generic strategy dinner for all of our ACOs to really kick off the year. What changed from last year to this year? What do we need to pay attention to? Where do we see performance last year lower than our expected? And identify those very early on as our kind of work efforts that we're going to track and monitor for upcoming quarters. I think on a 10 by 10 basis, there will always be variation in process. There will always be variation. I think, in knowledge and ability to just be tech savvy to pull down the file if it's a file where you have to do it yourself. So I think some of those communications do kind of have to be managed at the practice person level. But I think just having that one key contact inside the practice to say, hey, we have not received your QRDA1 file just yet. when are you expecting it? Are you having any issues? So that we're staying on top of it. We do ask our practices to provide our data or their data on a monthly basis, which I think for us has helped because it's a repetitive habit as opposed to saying, oh, only send it once a quarter or only send it every other month. We actually have calendar ticklers that say, QRDA1, time to send it over. So there's a little bit of repetition, and that was a huge ask from our practice partners. Like, give me a consistent time frame where we need to have this data over to you. I think that consistency is kind of key in making sure it becomes a habit as opposed to an afterthought.
Yes, habitual. Now, were you doing more of this through consistent emails, phone calls, office hours, a combination of all of it in the beginning? And then sort of, is there a preferred methodology now? Has that morphed over time in terms of strategy and how you're communicating with your TINs?
Um, For us, I will say not a ton of difference because we do things like the strategy dinners. We have a monthly leadership meeting. We do get to look at this information on a bit of an ongoing basis. I will say year one, as you kind of know, Amanda, like we were really at what, Q3, I think, when we decided, yep, we're still going to go ahead and submit eCQMs, got everything signed, started sending everything over. That was probably the biggest time where we had multiple streams of communication just because we knew we were really doing this at the end of Q3. I want to say, what was it, August or September, I think it was, when we finally was like, yep, we're doing this. It was somewhere late in that Q3 time range.
Yeah.
And so we had emails, we had phone calls, like we were really keeping up with them. But I think just, in our monthly communications now, it's a part of our conversation. We look at overall ACO performance now on a quarterly basis. But that's how we chose to build it in for a consistent, repeatable process. We always know, end of the quarter, let's look at what we have. Let's make sure everyone submitted what they have, and we pull it up on a, I don't want to call it a scorecard, but we make it facing to the participant tins. Like
Healthy
this is
competition.
where we are. Yeah, healthy competition.
And that's one of the things that I've noticed among ACOs that are very engaged and that have TINs that are very engaged. They are creating that healthy level of competition.
Yeah.
There's a lot of analytics that can be used in tools that are available, right, to create
Hmm.
that, again, healthy competition, especially for those TINs that are lower performers or just having trouble getting the data in. And you mentioned something about strategy dinners as well. That's an interesting concept. How is it all of the TINs that you're meeting with, or on a regular basis for these strategy dinners? How geographically, rewind a little bit. Let's go back to the TIN profiles and the
Hmm.
ACOs geographically. How, what type of distance? I mean, are some TINs closer with other TINs than geographically than others that you're meeting with in person?
Yeah, so our ACO placement is a bit, I think, geographical in structure. So they're all within a very similar region. And the independent practices are usually the practices that are already sending or dueling care with that hospital system. So we
Right.
tried not to break that bond and just the ACO setup. And, sometimes it happens, but that's a part of the thinking going. And you asked me a second part, and I honestly can't remember what it was, Amanda.
Well, just strategy dinners, like, so you're involved with those and the TINs
Strategy
are,
dinner, yeah.
it's an organized, it's something that's organized in advance. And yeah, I think that that's a useful look. Getting together and meeting with folks in person when possible, I think is also super helpful. I know the
Oh yeah.
virtual, most of us are doing the virtual thing now, but sometimes a face-to-face meeting can be a game changer in some situations.
Absolutely. We do the dinners, try to do them biannually, but we found, or the feedback that we received, is that it was very helpful to get off the camera and actually have a working session to
Yeah.
work through any and everything that we're working on that could be impacting performance. We do usually ask for um, at least one lead participant per 10. I will say that I think because of the traction we've picked up, we will get multiple people from TINs, and they're just different physician leaders at the different practices. But you really get to actually sit and think. It's not, the same as virtual. But you can whiteboard. You can see each other.
Yes.
You can do little breakout groups and work groups to think about the different initiatives and items that we have on our task list, and then come back as a whole and say, you know what, let's prioritize some of these. You're not going to get to every single one, and you think about that in terms of quality quality, like we had a huge work effort in just trying to make sure depression screening was correct. I think that that is the biggest measure that has haunted every ACO is
Yep.
what do you do with the depression screening measure, especially when you have specialists in the ACO. It's really a PCP style effort in most people's thinking for most organizations. What do you do with that? And then on the PCP side, how do you make sure it's documented? How do you make sure that second step, if it's positive, actually goes through? And I
Mhm.
think, working through something like that face to face has a lot of value as opposed to trying to do it all on a Zoom meeting or something similar. It's not to say you can't, but you really get people focused and honing in on just this is our issue. Let's figure out what we can do.
And speaking of 134 and data, because let's shift a little bit to the data. Now, for the audience, I mean, I know that you've submitted eCQMs, right? Because the
Hmm.
drive is, and we've been working on fire on the side, which is great in preparation for DQMs. So that's a little side baby
Yeah.
project. While we're talking about eCQMs, though, tell us a little bit more about, you know, what what your decision making process was in choosing eCQM. I mean, we know that that's the direction things are moving in, and so I think for 134, although it might seem hard initially to report it as an eCQM, there are a lot of benefits to reporting 134 as an eCQM. So tell us a little bit more about your sort of eCQM journey, and particularly Measure 134, maybe some things that you tackled with data acquisition for Measure 134 eCQM.
Yeah. So that measure, I think, from a data standpoint, was the hardest just to make sure we were getting all the pieces. I mentioned to this group, like, this is where we've had Patient 360 get on a call with us with a vendor. It was regarding Measure 134. They were not sending over in the files that we had any patient that was positive. We just seemed to be missing the fact that they should be showing as positive, and it had something to do with how they were programming in the EMR. I think across the board, for all the EMRs we've worked with, that's probably the most confusing measure to work through, particularly when it's positive and you need to document what your follow-up plan is. That's where we see like the structured text, making sure it's formatted the way it should be is very helpful, so that when we have to go back and have some conversations with a vendor, that we can actually point out, like, we're seeing this is what is happening, this is where it's documented, and try to have that collaborative conversation. Is it the right place? Did something update year over year in the EMR that made it move? So that one is just one that we hold near and dear to our heart.
And we talked a little bit about already sort of your strategy for tin communication, which is your it's multi-level, right?
Yeah.
What about strategy for, so you've got that communication, you're tight knit with your tins, you're communicating with them on a multi-level. What about how those tins are communicating with the EHRs, right? Because it's kind of like it's a three-step process. You've got the ACO leadership, you've got your team of resources that are working with the tins, but then sometimes the tins need to be working with the EHRs to get what they need to get. And so is there any tips, advice that you have for how to communicate with the EHRs? Because we do find some to be a little bit easier to communicate with than others, and to be able to have that line of communication open. Any tips or tricks or thoughts for for the ACOs listening there that have some TINs that are on EHRs that might be particularly troubling?
I would honestly say use every resource you have available. That includes the QPP, help desk, healthit.gov. If you think you're having a issue where they're certified and should be producing XYZ on a measure and are not, we definitely did that. I think it is very important to make sure your quality reporting vendor is involved in that conversation. I think we've had you in those conversations every step of the way, so we're hearing the exact same thing. A lot of our practices are not what I would consider on the tech savvy side. They know how to do what they're supposed to do in the EMR. They know how to pull down the report, but if there is a issue, a problem, they're not there to solve it. So I think, if your organization does not have the capacity to manage the EMR vendor conversation, try and do it as a partnership with your quality reporting vendor. I think that has helped a ton and saves us a ton of legwork of having to go submit the question on our own, go track it, go figure out what code may not be pulling in and capturing. So for us, I have to say that's probably been the absolute most valuable, is just having a partner that is in it with us, will help us try and figure it out. We still have, you know, are a couple of EMRs, I'll say, that are a little bit more difficult in the actual documentation standpoint with the practice. For those particular ones, I think it is just coming up with the most efficient way you can get it done. If your vendor's not willing to modify, their forms, they're not willing to modify their their setup for how something meets the numerator criteria or gets pulled into the numerator criteria. I think that is a little bit more difficult and challenging on the practice side. We have our one EMR, our providers always say, well, why does the vendor, the EMR, make it easier for me to document in this field? And I'm like, I'm sorry, but that is, the EMR decision. There's not much we can do to change that, but let's see if there's some way to make it a little bit more efficient and do something within our power.
And we attend office hours with a lot of our ACOs. They'll bring on the tin with the EHR, so we've done that. We've definitely, I think, collaborated and helped create consistent tickets, right?
Mm-hmm.
So if there's a pattern, we've seen, okay, well, this is an issue with, such and such EHR doing this weird password protection thing. Okay, let's create a consistent ticket that we can utilize over and over again, because that will also help drive change potentially with some of these EHRs if they're seeing the same issue over and over again. So definitely we've aligned with our ACOs on phone calls, office hours, and helping with tickets. So those are some good strategies. Anything that we need to know about data governance? So basically we have a structure within our platform where different folks can have user access. Anything that folks out there need to think with regard to data governance?
I think it depends on how they're parsing their data. For us in data governance, our TINs have access to the system to go in and look at their own information. We do not currently have the access set up where they can go in and look at the entire ACO. We did that very specifically because of our configuration of having the independents plus the hospital practices.
Yeah.
There's a little bit more that context that we want to be able to provide to do that. And I'm sure there's probably others out there that are in a similar position. Like, we want to be able to look at it, vet it, make sure it's good to go. There's no issues that we can detect before we show it. Not to say that we've had any, but that's just kind of our process for making sure, we're dotting our I's, crossing our T's across the board. I think that that's just something case by case, ACO by ACO, something to consider. A lot of our practices have asked for access. Can we go in and look at it for ourselves? Sure, but it's going to be your practice, not the ACO as a whole, because, excuse me, if, for instance, something happened and something didn't deduplicate, but we can catch it, we want to be responsible for that catch and not leaving that as a burden on the practice to try to solve on their own or to question. The other thing I think on the data governance side, it's not just like who can log into a platform and see it, but just making sure all the data is actually making it over. I don't consider that to be the responsibility of Patient 360 to ensure that, the practice is actually including all the providers that they should be. So we do have that, and on our side that, we do collect a roster from our practices on a monthly basis. We will look at that roster and make sure those providers are actually showing up within the file that we are sending over to make sure we're getting to that data completeness that we're looking for.
Yep. And throughout the implementation, we provide, okay, we should really have a Q1, Q2 at a minimum 4 quarters, each quarter sending us the updated provider list and engaging with that and looking at that. So good call out there for sure. Any other gotchas you can think of, or any aha moments that you've had along the way? Gotchas and ahas.
Ahas. Um, I'm going to say no gotchas. Ahas was probably with reconciling the providers. Was probably more of our aha, making sure that it's in sync with what's actually in the EMR at all times, to make that end of year QA cleanup a bit more amenable to do. Um, Other than that, I honestly don't think, making this transition outside of the EMR issues that we've had, that this transition has been one that is a hard one. It's been pretty beneficial, I think, for us on our end, and to the competitive side, I think, and Phil, for all of the ACOs we're working with, knowing that you still have that little bit of extra cushion with CMS to keep going towards eCQMs is also helpful.
Mhm.
Anyone that's looking at and tracking the benchmarks, you do kind of generically see, the benchmarks are a bit lower for eCQMs than with CQMs and Medicare CQMs right now, and we don't really have many measures that are close to topping out.
Yeah, which is good for the eCQMs. And then, of course, getting the practice now in and getting in the habit of consistently utilizing eCQMs when you can, because everything is shifting to DQMs. I know
Yeah.
CMS says they make it seem like it's going to happen tomorrow. We're probably a few years out, but it's still good practice, best practice to try to at least get familiar with it, even if it can't be in 2025, because I know there's probably some ACOs listening that say, well, we're not ready yet to submit all eCQM. We have to do MCQMs, but even if you can get some of your member TINs on board with submitting the eCQM level data, our platform's going to pull out the MCQM data for you anyway.
Yeah.
So those are just things to consider.
Or
A
even
little bit.
just, okay.
No, go ahead.
I was about to say, even just being able to compare. So if your
Mm-hmm.
ACO eventually wants to get to eCQMs, but you're in that CQM path now, that was a bit helpful for us. We know we were going from web interface to eCQMs for that very first ACO, but we
Yeah,
used it as a way to also identify gaps in performance that we need to keep an eye on, right? A1C, we know it needs to be in a structured field. When we looked at our performance, we were like, wait, but we have more in there. You can do those same types of checks across any of these reporting measures to just make sure there's a keen eye on this is what would happen if we weren't reporting this way. So if we were reporting in eCQMs, this would be your number. We're doing CQMs, this is now your number. We need
yeah,
to make sure we're creating a consistent process that would help us make that transition smoothly when you're ready.
absolutely. So let's talk a little bit about shared savings and outcomes. So maybe inspire some of our viewers, about what does the light at the end of the tunnel look like in terms of shared savings?
Yeah, so all of our three ACOs are enhanced track ACOs. Our one that started 2024, obviously there's been no shared savings there yet. But for our other two, our first year where we dual reported, we earned 6.2. This year, 2023, we earned 9.3 for one, and then 1.2 for the other. I think on our side, it's a pretty good way to just incentivize moving towards eCQMs. We're very competitive in nature, and we also, keep an eye on the fact that all of our ACOs are all operating within the same region as well, and just making sure we're trying to keep that competitive edge on with our practices. Cost is the one gateway to shared savings that you have control over. A pandemic happens, CMS will give you some grace, but you don't necessarily have control over that. Costs are continuously rising in healthcare. We don't necessarily have full control over that. There's aspects where we do, aspects where we don't,
Mhm.
but we're trying to take advantage of, what can we control ultimately is kind of quality. Where do we want to go? Where are we? And are we continuing to push ahead?
So let's talk a little bit, because I want to make sure we leave enough time for questions. Important to do. But
Hmm.
let's talk a little bit about preparation for the final rule, right? So, I mean, I think a lot of folks listening here have probably read the fact sheet, at least the basics. So we know nothing surprising, right? We know 112 is getting added. So maybe you could talk a little bit about how you're preparing, your TINs for ensuring that the EHR has 112 up and running within the first quarter of 2025, because it is something that has to be done, right? We do have to report 112 for APP plus. And then of course, again, we go back to the good thing about eCQMs. If you're looking at this, for the audience out there, you are going to get one additional point for reporting at the eCQM level, the complex organizational adjustment. So I like that better. It's carrot rather than stick.
Hmm.
any other things that you can think of that you're doing to help prepare, your member TINs for the 2025 final rule changes that are going to be put into place starting on January 1st.
Yeah, so we did give them insight into the proposed rule that the breast cancer screening, colorectal screening were potentially on the docket for 2025. Thankfully, we only got one, and the next one's coming in 26. But once we recognized that that was a potential to happen, we actually started um, what's the word I'm looking for? Looking into our EMRs. That's not the word that I wanted, but we actually started looking in to say, hey, is this measure already there? If not, let's make sure we get it added into our dashboard and let's start to take a peek at performance. We do have some change management to do there, similarly to some of the other measures of just, we know they're getting done. Let's just make sure they're actually making it to the right spot. So we have actually started that conversation. And then in Q1, we'll focus a little bit on just education to the practices, the staff, that this is now a measure that we will be reporting out as an eCQM, all patients, all payers. We got to pay attention to the documentation. So we will kick off in Q1 hosting what we call a quality forum, where we look at all of the measures, we look at the specs, how they've changed, and identify and answer any questions or gaps that we might be able to think of to kick the year off.
And I'm thinking, honestly, for those organizations listening now that are just recognizing now that 112 is part of 2025 reporting, start working with your TINs now and their EHRs to check and make sure that that measure actually exists within the EHR, that 112 is there. For a lot of them, if they are CERT 2015 EHRs, probably they've had that measure before, right? And so it's a matter of updating it and turning it back on. And I will say this about eCQMs, that the specifications for eCQMs, because a lot of people will say, well, CMS is always delayed with updating their specs. They are for CQMs, but eCQM specs are actually updated in the summer.
Yep.
So really there's no excuse for the EHR to say, well, we're not going to have this for the performance period. If they are certified 2015, the specifications for 2025 were already updated for these measures in the summer. So it's important to start having these conversations now so that in the first quarter, everybody's ready to go.
Agreed.
Anything else related to 2025 final rule that you can think of before we open it up for questions from our audience?
Not that I can think of.
So Garrett's probably going to pop on back in here. Let's have the questions.
That's right. Okay, so yes, we do have some audience questions, and if you do have a question for either of our speakers today, then go ahead and you can use you have like a module as an attendee that has a place for questions, and you can go ahead and drop them in there. We're going to get to as many as we can. We have a bunch of them that came through. If we don't get to yours for some reason, someone will reach out to make sure we answer yours via email. But in no particular order, let's go ahead and dive in here. First question is this. Does the MSSP submission for an ACO cover the MIPS reporting requirement for the TINs or associated linked to the ACO TIN? Does that make sense?
Yes. You want to take it or you want
Does,
me?
and it depends on your eligibility, right? So if you know your eligibility and you know that there are members within your organization, within your ACO that are MIPS eligible, then if you are submitting, right, those measures, then that it will cover. So the first place to start is with your eligibility. So double check and see eligibility of all the providers within all of your TINs within the ACO. That's the first. And then once you know that, you can connect with us and we will work with you to ensure that you're dually covered essentially. Tiara, anything to add?
Nope, that's
I
exactly
don't think
where my mind was going.
yours are all QPs, so I don't think you have any. I don't think any of your providers are actually MIPS clinicians. They're all, I think, QPs, at least partially or full QPs. Yeah.
Yep.
Okay, next question here is to improve quality performance for MSSP submission through eCQMs, should organizations focus on clinical interventions for identified MSSP patients, or should they focus on all patients, all payers?
I would say for us, we do focus on all patients, all payers, which is a bit different of a focus, but I think if you were only to focus on your MSSP patients, depending on whether you're in a prospective model or a retrospective model, you could potentially be putting your performance in jeopardy. The patients that are hitting the bulk of our denominator are ones that are outside of the Medicare fee-for-service payer type. So we do, when we speak to our practices, it's all patients, all payers. Let's have a standard process. And I think across the board, if you're talking about, practice and practice efficiency, they're really looking for ways to treat all of their patients the same. They don't want to have to think about the payer. So I would just be mindful of that piece of it.
And something to add to that is that MCQM reporting, because the person that asked might be thinking, well, I'm going to do MCQM reporting at the moment, but MCQM reporting is not going to be around forever. So when it does move to eCQM reporting permanently, it is on all payers, right? And so that you don't want to start with just saying, well, let's just look at the MSSP beneficiaries because we're doing MCQM anyway. It's going to move to eCQMs in the next couple of years. So may as well you get started now with getting in the habit and the practice of focusing on the all payer population.
Right. Next question is, do all the TINs or are all the TINs on the same EMRs? If not, do you get data only in QRDA1s or other custom CCDA formats? And how did you handle in scenarios like that? Does that make sense?
I think so. So ours are different EMRs.
Yep.
We have asked that they all send them over in QRDA1 files. However, Amanda's familiar that we do have a group that has a particular challenge getting that QRDA1 file. I think depending on whether you're doing what I'll call mixed reporting or a single, so we push for eCQMs, but have recognized there is a case where we may need to switch off to CQMs for a particular measure if we can't get what we need out of one of our EMR vendors, where that would be a different quote unquote file type that you need to look into. So I would say make sure you're paying attention to the measure. You can have, you don't have to do eCQM for every single measure. You can mix and match what you do for each measure, but for that measure, there has to be consistency. So if you need to do CQMs for depression screening, but you think A1C for eCQMs looks okay, you can do that type of mixing and matching.
Yep, and we see that all the time. And exactly what you said, usually 1 and 236, because QRDA1 files for those are pretty clear cut in terms of the SNOMED and the value sets and the codes used. 134 is more nuanced because it's a layered measure. And so we will see more often than not, if people are going to drop to CQM, it tends to be with 134.
Perfect. All right, moving right along. Next question is, are all your ACOs doing some chronic care management, and are they doing it in-house, if so?
We have a mixed model for chronic care management. So we have, sorry.
I hear your dogs in the
I'm sure you
background.
all can hear
That is
them all in the
okay.
background. I apologize.
They have a lot of opinions about this, I can see.
Yeah, they're excited about ACO reporting.
Sorry about that. So we do have chronic care management that we offer support services to our practices, and we do have some practices that take on that type of work on their own. So I think across our ACOs, it's a bit mixed. We do have some proprietary work where we have our own risk-based model to identify patients that we consider to be high and rising risk, and we push that information out to our ACO 10s to review and then let us know where they need additional supports if it's something that they can't do in-house on their own.
Great. All right. Next question here is, this is actually, and I promise this is not something that was like a seed or a plant question. This actually came in from an audience member. Says, not a question, but wanted to share that Patient 360 is a fantastic, supportive patient and skilled partner in this network. As a new ACO client in 2024, we have been so incredibly impressed and happy that we chose them. So anyway, I thought I would just give a little shameless plug to Patient 360. So well done there.
Thanks, audience.
Sure. Okay, next question is this. How do you ensure data completeness when you are already reporting for all the patient, all payer data?
I have to
I
say
can
I rely on Patient 360.
Yeah. We have our platform basically will show you if it's eCQM data, we have several areas in our analytics tools that will show the population. And can you hear me okay, Garrett? Okay. So in the analytics, you can see there's multiple areas where it will show you what data was received, when it was received, how much was received, and when the last date it was received. Multiple areas in our platform to look at that for eCQM data and for the QRDA ones. Typically speaking, with a QRDA1 file, inherently, if you're sending a year-to-date QRDA1 file as an eCQM, the certified EHR is meant to be able to export those files. So organically, you're going to meet data completeness if you're sending the full year-to-date QRDA1 file because it has all the data in it. When you run into issues with data completeness, where our platform also tracks for you is the CQM data. So if you're manually manipulating the data and sending over data via CQM onto a template, our platform also has analytics that will show you when and if you're not meeting data completeness. And the only time that would happen, and it's very, very rare, is if we have practices, for example, I've seen this a couple times with specialty practices where it's a TIN that's a very specific specialty like derm, for example, and they're not really tracking these particular measures as part of the ACO. So they'll send over that they've the denominator population in the CSV template, and then they'll leave the numerator response or the quality action blank or not reported. It is okay to do that in some circumstances, and mostly because the patient will probably be seen by another provider within the ACO, and that will cover that instance or that patient. And or you're allowed to have 75% or higher of data completeness. So as long as you don't drop below 75%, so as long as you don't have more than 25% blank numerator responses on your templates, you're okay. And our system, our software will show you that when you fall below the data completeness. And again, it's very rare because these are instances where it's typically really small practices or certain specialties where this happens with. So it's not a very high population. So in most cases, you are going to meet data completeness, and our software will tell you when you're not.
Yeah, I think that's an important reminder too, because I know you gave us that reminder when we were looking at reporting options. It's 75% on the numerator, not necessarily the denominator.
Great. All right, next question is this is kind of a two-part, but might be the same answer. We'll see. Are MVPs or MIPS value based or value pathways something you are preparing to transition to or are exploring? It seems like MVPs have a higher reporting burden on practices, and managing so many measures for so many specialties seems a bit overwhelming. Any thoughts on how you are preparing for this that you can share? Thank you.
I can start off from the patient 360 perspective because we're a qualified registry and a QCDR. We are mandated, so we have to report MVPs for all of our quality payment program participants who wish to submit the MVPs. So we already have that built into our system. So essentially, when data comes over to us for quality measures, if any of our clients wish to report the MVP, they just mark that off in our system, in our platform, and the software then displays the score for the MVP that's been selected accordingly. Some advice I can give to folks that are interested in reporting MVPs are that you actually have to register with CMS for the MVP to be able to report it. So for 2025, if you're preparing for that, the registration will open in 2025. And then you would just submit data to us the same way. We would receive quality measures, and then you would just indicate in our platform that you want to report the MVP and which MVP, and our platform will display a score for that MVP accordingly. So that's in general a patient 360 qualified registry and QCDR response at the sort of meta level, right? Because we submit for all, we submit APP reporting, we submit MIPS, we submit MVPs, and we submit QCDR measures that we've developed on our own. And so we have all of those available, and you simply designate what you're submitting, which program you're submitting for in our software, and then it will display the score accordingly. Tiara, do you have anything to add about MVPs in particular?
No, because I think on the MSSP front, we're still waiting to see how that interaction is going to work with APP Plus. But for our practices that do happen to be looking for a solution, we typically point them in the patient 360 direction if that's what they're looking to do, and their current vendor or EMR doesn't allow for it.
Yeah, great. We got time for a couple more questions. Again, if you have one, go ahead and drop it in using your control module there. Next question is this. Tiara, you mentioned including specialists within your ACO. Could you share a little bit about what conversations or workflow changes were discussed with them to ensure quality measure success and their general feedback of the change required?
General feedback, I'll start there because that's the easiest
There
one to
you
answer. It was not favorable.
go.
They they generally speaking do not like any parts of the APP reporting. Our conversation and ask right now has been that we want them to update the PCP documentation that they have in the EMR. That is our biggest ask of them today. What we have found and the ability to deduplicate is that many of those specialty patients are seeing a PCP somewhere in our ACO where we have not had to provide them a huge burden as to we need you to go work through XYZ measure. We have asked them to update the PCP on the off chance that the PCP is outside of our ACO, that it enables us and our quality team to have the ability to do some outreach. The measure does not say that it has to be scored at the specialty practice. It could be something that is sent over in a CCD form or something similar over to that EMR, and it will pick it up with the same date from the primary care provider's chart to enable us to meet the measure. I would say that that's probably something nice to consider. Just start with the basics and getting them engaged. We have other opportunities where we're working with them to manage costs on different levels. And I think just having a baseline relationship with your specialty providers before you go ask them to do quality work is probably important so that they don't just kind of slam the door in your face in the conversation because they don't want to work on measures that are not pertinent to their specialty.
Great. Okay, next question here. MSSP attribution in an ACO with multi-specialty, mostly MDs, and primary care that have MPs and PAs. How to regain those patients back to primary care? Don't
NPs
know.
and
Does that
MPs.
make sense in terms of the question?
That does. From an attribution standpoint, if you haven't looked at the role of voluntary alignment, that could very well be worthwhile. Another strategy that some of our partners are using is that even if they primarily see a mid-level provider, they are trying to ensure that patient sees a physician at least once a year. Either of those options kind of work if they want to designate who their PCP is. I would just keep in mind that kind of voluntary enrollment, it does need to align to the provider that is in the practice still, not the mid-level. I think many ACOs have been hoping and keeping our fingers crossed that CMS will come up with a better logic that accounts for mid-levels. We have a ton in all of our ACOs, but I don't think we've gotten there just yet.
Great. We have time for one more. Hopefully, maybe it's a quick answer. We'll see. I'll ask this, and unfortunately, we'll have to wrap up. But don't worry, if you asked a question and we didn't get to it, someone will reach out via email to answer it. And the last question is this. On updating practice EMR, will it be beneficial to ask every practice to have their patient names identified in their EMR by the exact name as shown on their Medicare card? And would that help with duplication?
We dedupe though, right, Tiara, on 4 different, it's like patient name, date of birth, gender. So we're using, it's more than just the first and last name, although it is helpful to have that, but it's more of a triangulation of all those points for
Yeah, I think the
deduping.
other yeah, I think the other thing I think we look at is address. I would almost urge against using the member ID number for any payer because if they switch, especially if it's a Medicare patient and they switch, those numbers change so frequently that it really doesn't help you in the deduplication process unless you are maintaining some type of crosswalk, which I will tell you is a ton of work.
I'll bet. All right. Well, hey, Tiara, Amanda, this has been a fantastic presentation. Unfortunately, we are out of time. We need to wrap up here. But as we close out, wanted to encourage you all to head over to vbcexhibithall.com. And when you're there, you will find the Patient 360 virtual exhibit booth. There's also going to be a link directly to it in the slides that we'll send out soon. And here you can read up on them, seeing what they're doing in the space, kind of educate yourself on some of their services, and of course, reach out to them through there. And then also, there's a lot of great resources in the library there, which is also where this webinar will be archived. So again, head over to VBC Exhibit Hall. And then finally, if you would like to reach out to our speakers today, feel free to reach out to John here, and he will connect you. John at patient360.com, and they will put you in touch with the team. I'm also happy to facilitate an introduction if you want to reach out to me directly. Thank you all so much for spending your afternoon with us. I hope you join us for the next one. Until then, have a great one and enjoy your holidays, because those are coming up soon. Thanks so
Yep.
much. Bye-bye now.
Thank you. Bye.